I'm going to give you a brief introduction to diabetes, and I'm also giving you an overview over some of the work we're doing in the lab, in particular our efforts towards developing cell replacement therapies for type 1 diabetes. Although I always think there's a little bit of a misnomer there, because successful cell replacement therapy, truly successful one, would constitute a cure for the disease. So over 1.25 million Americans live with diabetes. There are 200,000 under the age of 20. There are 40,000 individuals diagnosed each year. Most of those are children and adolescents. And a worrying statistic shows that type 1 diabetes, can everyone hear me? Okay, great. Worrying statistic shows that the prevalence of type 1 diabetes is actually going up. And between 2001 and 2009, there was a 21% increase in the prevalence of type 1 diabetes, and we really don't understand why that is happening, but unfortunately it does show that type 1 diabetes is a growing problem in our community. As we are also painfully aware of, type 1 diabetes associated healthcare expenditures are staggering, topping $14 billion annually only in the US. So what causes type 1 diabetes? It's an autoimmune disease where the patient's immune system mistakes the pancreatic beta cells to produce insulin as a foreign invader and starts attacking it, which leads to its progressive destruction, forcing patients to artificially regulate their blood glucose levels with insulin injection and sort of controlling the diet as well. So 98 years ago, insulin was discovered as a therapy for type 1 diabetes. It was really a medical breakthrough. However, in the last century, a century later, we're still dependent upon insulin administration for therapy for the disease. So managing the disease with insulin injection is intensive and imperfect, so it's understandable that some patients are frustrated with that. However, luckily, advanced delivery systems such as the artificial pancreas have really greatly alleviated the day-to-day burden of the disease. And we're very lucky tonight to have world leaders on this topic on the panel tonight, so I'm really looking forward to that conversation. There is an opportunity in all of this, and that is that only a single cell type is destroyed in type 1 diabetes, the pancreatic beta cell. So the only thing that separates a healthy individual from a type 1 diabetic is that this cell type has been destroyed or is dysfunctional. So if we were able to replace that cell, that would bring us pretty far. So what we do in the lab is we take patient skin cells or blood cells, and we use the advanced robotic system that you may have seen when you entered the institute on the 3rd floor. If not, I recommend you take a quick peek when you're on your way out. And we use that system to derive patient-specific pluripotent stem cells. And pluripotent stem cells can become any part of the body. You can change them into liver cells, heart cells, brain cells, or in fact, pancreatic beta cells. And in the last 3 to 4 years, me and my team, we've been trying to leverage the technology that we have available to automate the derivation of functional pancreatic beta cells. And once you have these cells, you can do a number of things. One of them is disease research, where you can start asking questions like, is there something particularly wrong with pancreatic beta cells from type 1 diabetics that you don't see in healthy individuals? And upstairs, we're combining the automation technology we have with artificial intelligence to help us answer that question, which is quite interesting because if you do see differences, you can perform high throughput drug screening to identify ways of sort of correcting that phenotype. We are always looking or recruiting patients to donate samples to our studies, and Lillian will be standing in the back if anyone is interested. Oh, there she is. If anyone is interested, we have flyers to share. But what I am the most excited about, and what I think is the sort of end game in what we're trying to do here, is to use these cells for the development of cell replacement therapies. Before I go into that, I just want to give you a little bit of a peek behind what's behind the robotic icon that we have here. In the laboratory, we use high throughput liquid handling robots that allows us to grow cells on plates like these, which have many which have many little dimples where we're able to grow pancreatic beta cells in little clusters that look very similar to the islet of Langerhans, where the beta cells reside in the pancreas. I hope you appreciate that in the size and shape of these organoids is highly uniform, which allows us to make very exact measurements and comparisons when we're comparing cells from different individuals. If you peek even further, you'll see that when you stain these cells, you'll see that the green color here indicates the cells that are positive for insulin. So these are functional insulin-producing beta cells. The paradigm behind stem cell-based replacement therapy is pretty simple in theory. You take patient skin cells, your derived patient-specific stem cells, you change those into pancreatic beta cells, and then you transplant them back into the patient. Simple enough, right? However, the problem is that type 1 diabetes is an autoimmune disease. So even if you make the perfect pancreatic beta cells using all the fancy technology that I was talking about, these cells will immediately be attacked and destroyed by the immune system. So there's a huge challenge here, which is how do we protect the transplanted cells from the immune attack? I should mention that we know from animal studies that we are able to reverse diabetes in animal models. We also know from transplanting islets from cadaver donors that we can often see remission of the disease. So we think that there is a lot of proof that cell replacement can be a viable cure for type 1 diabetes. There are, however, major challenges, and this is, I think, the central one. So evading the immune system is, however, not easy at all. So the immune system has been evolving over millions of years in constant battle with pathogens, which are trying to sort of break its defenses. And there are two things to note here. One is that it's an extremely robust system that is basically designed to avoid any kind of perturbation. And number two, we desperately need a functional immune system to fight off pathogens. So trying to modulate the immune system for it to stay off pancreatic beta cells, which it views as a foreign invader, while still being functional towards pathogens. It's just a really tricky thing to do. So in type 1 diabetes, the cells that are driving the autoimmune response are called T cells. However, once the autoimmune response has started and the pancreatic beta cells are being attacked, a plethora of different immune cells have been associated with targeting of pancreatic beta cells, only a few of which I'm showing here. And all this to show that if you try to target the immune system with immune suppression, if you target only a single cell or let alone only a single pathway, it's unlikely to be sufficient to completely halt the immune system. And like I said before, we do need the immune system, so you can't really go overboard and just eliminate or knock that down. Another approach is, which a lot of companies and researchers adopted early on, was to place the cells that we want to transplant into encapsulation devices. And the idea was that these devices would keep them separate from the immune system. And I think they do exactly that. However, we here at NYSCF, we made a conscious choice not to pursue this early on. And the main reason for that is that in the same way that these devices keep the immune system at bay, it also separates the pancreatic beta cells from the host. So these cells will never fully integrate into the body. And that means that inevitably, unfortunately, these cells will start dying off. And that means that you'll have to replace them. So you're sort of moving away from that cure paradigm and into sort of an elaborate, complex therapy that is potentially invasive as well. I will say, though, that there's very active research into all of this. Immune modulation, encapsulation, there's improved data coming out every day. So I'm not saying that there's no way this will work. We just chose to go another path, which we think might be a longer shot, but it has actually has the potential of getting us where we want to be. So we spent a lot of time thinking, how can we leverage the stem cell technology, which was sort of providing so much promise, but we wanted to make sure that we weren't doing incremental steps. So the idea we came up with was to use a then emerging technology called genome editing, which allows you to go into the cell's DNA and do modify it in very precise ways. So you can take out genes, you can add genes, you can control which genes are being expressed each time. So it's really a phenomenally powerful technology. And the idea here was to modify the stem cells in a way that they would become less visible to the immune system. We call these immune camouflage cells. And this work has been done in collaboration with Deepta Bhattacharya at the University of Arizona. It's been a really fruitful one. So as crazy as this diagram looks, and it does look crazy. This really was a crazy idea in the beginning, but luckily enough, Susan likes crazy ideas as long as success means that we actually get somewhere. So she was on board right from the start, and that sort of made all of this happen. Early on, we pitched this idea to the JDRF, and they provided what I would say visionary and somewhat brave support of this early idea. So once you have these camouflaged stem cells, we then change those into pancreatic beta cells, and the idea is to transplant these back into the patient. And even though they have an ongoing autoimmune response, or are at least able to launch an autoimmune response, these cells will be unaffected as they are not recognized by the immune system. This paves the way towards, which sort of creates a potential for permanent engraftment. So on paper, if this means that you could, a single transplantation could mean a lifelong therapy for the disease. So there's definitely a high reward there. And some of you may have seen, noticed that I don't have this sort of triangular diagram here. And that there's no arrow here from the patient to the stem cell. And that's because if we are successful, or truly successful in the immune camouflaging, that means that we don't have to use the patient's own stem cells, because these cells won't be, we don't have to worry about graft rejection the same way you would if you donate a kidney, because these cells won't be visible to the immune system. So this means that you can generate these cells in large batches and transplant them into thousands of patients. And beyond just the practicality of that, that would lower the cost of a therapy like this by orders of magnitude. And really, in my mind, again, this is all dependent on this working out, but it would become an obvious societal choice to provide a therapy like this for patients. So just to leave no doubt that this is an ongoing research. We're very encouraged by the results that we've gotten, and everyone is very excited about this. It's been a real pleasure working with the JDRF on this. They're much more than a funding source for us. We talk to them often on the phone, and they're not sort of calling to check in if we're doing our job. They're more sort of asking, is there anything more we can do to help you guys be successful? So it's really been a pleasant experience. So just 3 take-home messages. Stem cell technology allows us to create functional pancreatic beta cells in the lab. Genome editing shows promise for evading immune attack upon transplantation. And this paves the way towards off-the-shelf cells for transplantation into any patient. This work was early on supported by the JDRF. The beta cell automation and the beta cell production protocol was funded by NYSCF and the NIH. And really from the start of this project and the start of this program, I've received critical support from, sort of foundational support from the New York Stem Cell Foundation. And that is thanks to generous philanthropic donations. And what these donations mean is that it gives us a space to sort of think big and go after these big ideas. So I'm just really thankful, and I feel very privileged to be in this situation. Thanks so much.
So for many years, I was a clinician, predominantly providing care to patients with diabetes, which I truly love and still do. But then start to think about, what can I do to give back and make this a little bit broader? So what I do now is, as Ben mentioned, I'm the director of a robust artificial pancreas program. We're expanding that even further. So what is an artificial pancreas system? Insulin pump, glucose sensor, and basically an algorithm with which to help better manage glucose levels. Many people with diabetes are quite good at taking care of their blood sugars, but they're not perfect. Nobody is perfect. I'm not perfect. No one in this room can ever be 100% perfect. So that's where machine learning can really take over and relieve some of the burden. Person with diabetes, basically every minute of every day is thinking about what's going to happen next. So I'll give you perspective. I walked over here from the subway. That's multiple blocks. Well, that's kind of challenging because your blood sugar may drop when you're doing all of that.
Mine has on my walkover.
Yeah, and I was like, oh, and I was like cursing. It sounds like, let me get some fruit. Let me deal with this. No matter what automated system I'm on, I still have to think of it. But it's on the back burner with this machine learning. People can go to sleep. They don't worry as much. What am I? Am I the cure? No, I'm not the cure. I'm not even close to the cure. But I like to consider what I'm doing right now a bridge to the cure.
I started in 2004 as a junior scientist at JDRF working in diabetes complications. Hypoglycemia research was a big focus of mine because my brother has hypoglycemia unawareness. He's had probably over 100 hypoglycemic seizures in his life. And that's what started my interest in artificial pancreas. And I smile because Carol and I have worked on that project for a while now. So here I am now heading up JDRF and looking at the variety of different things because, artificial pancreas, as Carol said, isn't a cure. I've yet to meet a person who wears an insulin pump who doesn't have diabetes. So it's a great advance. I've benefited and my brother tremendously, but my goal is what Bjarke talked about here, which is restoring insulin independence.
I was diagnosed in medical school, and I thought, as many medical students do, maybe I'll do surgery, maybe I'll do cardiology. And then I was diagnosed with type 1, not having a lick of it, as we know, in the family, because it's most common to not have anybody in the family have it as well. I think you're kind of a rare bird in a way, right? And I thought, man, this would be too much to live with and work with. But pretty soon after diagnosis, I realized, there has to be a reason for this. I mean, this really sucks to have it, right? But I might as well do something good with my training and my time. So I decided to go into endocrinology, and early on in my career, I was very interested, and still am, in international medicine. And I had the opportunity to spend some time abroad, and I very early on and clearly saw the struggle of living with type 1 diabetes in resource-poor settings, be it sub-Saharan Africa, and honestly, many parts of the United States. So I find myself realizing that if I were born in a place like Uganda, where Marjorie's Fund is based, I would be dead. I wouldn't be up here talking to you. And I happen to be born in a place of privilege. I'm also a consummate optimist, and I like to try to give that optimism to some of my patients who, as we all know, suffer from diabetes burnout, which I think is one of the biggest plagues of our community. Because no matter which tools we have, if we don't use them accordingly, then we suffer the complications. And you look at the data in the country right now, regardless of all of the automated, pseudo-hybrid artificial systems, whichever you want to look at, we're not doing a very good job. So I'm very interested in and optimistic that there will be a cure. I don't think any of us know particularly which exact avenue that will be in. I think that the research that's being done here is extremely promising, but I do think it's coming. But I tell people, you know what, we have to tread water with whichever system you're using to manage your diabetes. Tread water until there's a cure, because when there is a cure, you don't want it to be too late for yourself. So again, this is kind of the message I try to portray to my clinical practice and also the international patients who are very interested in the opportunities for a cure.
What is your sense of how we treat today, and how has it changed from when you first began?
Ian, so that's a great question. So I think over time, one of the biggest contributions, ironically enough, I don't think, and I think everyone on this panel will agree with this, is insulin pump therapy is great, but really the game changer for most people has been continuous glucose monitoring. For people not familiar, what is that? It's basically a way where there's a sensor put under the skin where you can continuously see what your blood sugars are every 5 minutes throughout the day. Think about this. Patients with diabetes used to prick their fingers multiple times per day, but you were only seeing one spot in time. Sort of like you're walking down the road, but you're only seeing the stop sign. You're not seeing all the distance down the way. So continuous glucose monitoring has been shown in multiple clinical trials, many funded by JDRF, showing the benefits regardless of what type of treatment you're on. You can be on injections, you can be on insulin pumps, you can be on any of them. It gives the patient and the clinician, and really more the patient, the day-to-day that really can make a huge difference in terms of management. On the other side of that, as Jason alluded to, it creates more burden though. So here I am looking at my sensor, worrying about this. We have to also think about the burden of all of this in terms of self-care, and how do we kind of tease all that out, and how do we support people who are really trying to navigate this, live long and healthy lives, and not be overly burdened.
I'm smiling because it's just, I've been on that platform for a long time, and now here we are, and I haven't poked my finger in a year. And
Not even to calibrate.
No. And, I'll give a funny anecdote. It's funny and sad, but my stuff was stolen out of my car in San Francisco last year. And so that's the sad part. The funny part on this story is it was about a month later that I realized my blood sugar meter was stolen. And that was like, wow, that's friggin' awesome. And I think the CGM wave and the improvements in CGM have been amazing. The G6, the Libre, the calibration-free sensors. But I'll tell you, the automation is where the action is. And anybody on a hybrid system, the Control IQ, I think the Medtronic 670G kind of blazed the trail, maybe almost a little too fast. But these next-gen systems, I looped for 4 years. I went on to Control IQ about 3 months ago. It's game-changing because it hits both sides of the equation. Better diabetes numbers, and whatever you define that is that you're trying to do. Is it trying to get my A1C down? Is it trying to get low less? Is it trying to sleep better? Is it trying to have better variability, less variability? It does all of that, but it does it with less work. And that's where, again, I'm really excited because now we're seeing this freight train of advances coming on this front. Multiple systems, multiple sensors, multiple algorithms. Plug and play is a big thing JDRF has been working on, and that'll make life easier.
Let's pull back a little bit. So I think many of us take for granted when you use a term like closed loop. What exactly are we talking about, and what does it mean to connect a pump and a CGM in practice? Any of you, please.
Sure. So basically what it means is you've got an insulin pump, you've got a glucose sensor that you're wearing, and there's an algorithm, just like you think about a computer, that basically decides how to run it. So data from the sensor goes to the pump, which then has an algorithm or a mathematical modeling equation within it. It incorporates that information and then says, okay, wait, I anticipate this blood sugar is going up, or I anticipate this blood sugar is going down. Let me adjust the insulin doses for that. Are these free of burden at this point? No. Patients still have to dose for meals. So for people who are not familiar with what that means is, I'm sitting down to eat dinner and I'm having a piece of pizza, I gotta go, wait, what do I have to do for that? I gotta figure out how to still dose for it. But what these systems do is they figure out how to clean up the mess. Let's say I make a mistake. I don't dose for the pizza correctly. The system will adjust the insulin dose to correct that.
I'm a definite lover of technology, but I don't think that a technological advancement is really going to fit everybody. I think that, the thing about type 1, sometimes we have to go back to the basics, and it's a beautiful thing for people to be able to pick and choose which system they would like, be it which pump they would like, or which sensor, or which types of insulin, or which type of glucometer. But again, I do love sensors, and I feel a little bit naked right now because my Dexcom sensor wore out and I'm not wearing one, and I'm like, oh my God, but I still stick because I find for myself, and it's not the case for everybody, but that too many times it's not accurate enough for me, and it would have misled me in certain situations. And it makes me realize that we've come a long way with the technology, but we have a long way to go still. And I'm definitely looking forward to the G7s and the next generations of sensors, which I know are coming and they're going to be better. But I think that, again, from a technological standpoint, I just wanted to say I don't think there's a one-size-fits-all.
The one thing that I will say, just to follow up, because I want to get into stem cells, is even the basics. One of the things that we've learned in this study, these are lots of studies, is, for example, just to point out that the basics are not enough. The average basal rate, so how much insulin you need night to night, when we do closed loop studies, you can measure how much insulin did you really need. The variability is 300% night to night. So if you have a dialed in basal rate and figure out everything you need to eat and do whatever you need to do, you have a window of almost 3x day to day depending on all sorts of circumstances. And anybody who's read Adam Brown's book, there's like 50 plus things that can affect your blood sugar. So I think it's fair. It's fair. But the bottom line is, with today's tools, the bulk of people can't get, even the most aggressive managers, great A1Cs without hypoglycemia. So that's why I think these tools are helpful. They're not the end game. Where the end game is changing the course of the disease.
What would a cure mean? What does a cure look like in practice?
So the way I see it is a cure is something where you go and you have a treatment and then you don't have to worry about it afterwards. That's a true cure. There are therapies that approach that. Maybe they're minimally invasive. Maybe you only have to go to the physician every year, but that would still be a therapy in my mind. What we sort of are aiming at or gunning for in our work is to get to a place where a single transplantation in our case would be enough to be a lifelong, cure for the disease. That's the end goal, and that's where we intentionally went. There were lower hanging fruit to be had on the way. There were encapsulation devices to be tested with our cells, etc. Luckily, I wasn't, obliged to publish every year with the generous funding of NYSCF. So we were able to say we want to go all the way up there, and we're not going to get distracted on the way. So that's a little bit how I see it.
So can I just, I have to weigh in, because up here we have the term cures plurally. And I was just going to ask an audience participation question. How many people were promised a cure within 5 or 10 years? Yeah. So I think this shift to using a plural on cures is very, very important. And I just want to give you at least the JDRF perspective, which I'm sure is the NYSCF's perspective as well. There is a lot of frustration in the diabetes community about false promises and what is a cure. There is no a cure. Just like there is no singular artificial pancreas. It's a series of more and more sophisticated systems, plurally. And where that promise came from was islet transplantation. That islet transplantation was going to cure type 1 diabetes. And when, so that the frustration, and I want to why we on this panel are optimistic and the difference from back then. I was with, and I think I may have said this at the last NYSCF panel I did, but it's worth repeating. I was with James Shapiro from Edmonton, who did the Edmonton protocol, an islet transplantation protocol back in the 90s. Famous islet surgeon and transplanter. He still has people 2 decades later off insulin with a spoonful of cells. So if you wonder why there were the promises made, there were people like my brother who had complete hypo unawareness, who were crashing their car, ending up in the emergency department, on the floor in seizures, coming to meetings and saying, I'm cured. And if you talk to these people, I know islet recipients, in fact, I'll see one in a couple weeks in San Francisco, they will tell you they're cured. But that cure was only appropriate for a small amount of people because it was cadaver based. Somebody had to die and give their pancreas, and it requires chronic immunosuppressants. So the reason we talk about cures, I think, is very, very important, and why NYSCF is on the front line here, is we're looking at different approaches. There's a variety of ways that we're going to tackle that. And the barriers to making that real, a renewable cell source. So Björk talked about, could it be an induced pluripotent stem cell from your skin, or an embryonic stem cell, or somewhere else? Could it be a gene-edited cell or an encapsulated cell? There are going to be a variety, and I think NYSCF, the story here of the pioneering work that's happening, that Susan and the team have catalyzed, there's no singular approach. But the promise is very, very real.
So what are some of the key developments in the field since Edmonton that have allowed us to get to this place? And it is not just a change in perspective, central as that is. Yeah,
I think in the stem cell field, there are 2 critical things. One is a major effort has been put into developing the protocol to change stem cells into functional pancreatic beta cells. And it really was a painstaking process where basically everyone in the field was bogged down trying to figure that out. And I think we're in the sort of last meters of figuring that out. And so that's one big hurdle that's been overcome. The other thing is immune evasion of the graft. How do you protect a graft after transplantation? In the cadaver donor situation, you have to be on immune suppression. It's not clear, or it was pretty clear that that's not an acceptable therapy for most diabetics. They're able to control their diabetes relatively well with their insulin regimen. So the risk of going through that is probably unacceptable. So that brings us to encapsulation, where you take that out of the equation. But that brings, again, in that balance, are you willing to have an operation? Right now it looks like every 6 to 12 months to replenish those cells. A lot of people would say no. Some people might say yes. And what we're trying to gun for is to take that next step of lengthening that time where you can get a transplantation and not have to worry about it for as long as possible.
You mean essentially to change the equation for a larger number of people, to make them more and more inclined to say yes.
Right,
Yeah.
exactly.
I think, if you look at what New York Stem Cell is doing and other labs, you have now enough cells for everybody. I mean, there have been 5,000 islet transplants all in the last 20 or so years, 30 to 40,000 new diagnoses in the U.S. every year. So you have a huge supply and demand issue. But you take what's going on in the lab and then you have to scale it up. You have to make it applicable to everybody. You have to commercialize it. And I think that, folks who haven't seen the facilities up here, it's absolutely stunning. What does it take to do mass production of cells? What does it take to make a product out of an induced pluripotent skin-derived stem cell? I think now there are companies and organizations like JAX-NYSCF who are doing this. Before, it was in individual academic labs with one investigator or a group. Now we have companies. We have Novo Nordisk, Lilly. You have Sema, just acquired by Vertex. I mean, these are major players. And the barriers that are being broken down on the last kind of, it's a marathon. And I think we're probably in the last 10K now. And, folks, I run the New York City Marathon a lot. So it's in my head coming through the Bronx back into Manhattan. But when you see Manhattan, you feel pretty darn good. And that's how I feel right now with this stem cell work, because we are now moving into humans, where in the past we were curing mice, as we've seen.
So then what is it that still needs to happen to get us into Manhattan and over that line in Central Park?
I have the mic, I'll talk. So, I would say as a clinician, and again, I'll preface this by saying I'm not a researcher, I'm a clinician. I have patients come up to me all the time, when is a cure coming? Do you know of any trials I might be good for? And you have to kind of weigh in your mind what the immediate promise will be to them versus what the drawback will be. And we've talked about immunosuppression. I think that what's really going to revolutionize and open the door for people to be able to more widely participate in these things are when we can negate the need to suppress their immune system, because when their immune system is suppressed, in order for these cells to survive, it opens the door to a host of things, including infections and lots of different aspects that can be troublesome to them in the long run. So I think that we're going to see the ability to, when we see less of a need to immunosuppress, we'll see a huge number of people knocking on the door to get this done and enroll in trials. As of right now, it's really limited to those people who either really want to contribute to science and are very interested in the topics, of which there are many of us who are. But the reality is the majority of things that have been tried have not been necessarily beneficial for that individual in the long run, and it's led to a lot of this discussion of cures never coming, and again, perpetuated this burnout, we're never going to get it concept a lot of people have. But I think what I find as a clinician most exciting in the conversations I'm having with my patients is that the way that things are going about when we talk about camouflage, which I think was a really cool slide, personally, sorry, is that it really makes all the difference if people can actually, if I can in good faith tell patients, go for it. You know, you have very much less to potentially lose by doing this. It may not work, but you know what? You're unlikely to have a lot of negative consequences from this. Again, I think that the immunosuppression piece is the biggest piece. Once that truly changes, that will open the door for people to flood into taking advantage of all of these cells, for example.
So Bjarke, in your estimation, what does need to happen to make this a reality?
I think scientific funding is really the key for all of these. And I think concerning when is the cure coming, I think 10 years ago, if you look at investment in these cures versus therapies, there would be almost none, I would probably say, or very low, versus all these large entities now pouring money into the field. So I think that's a good prediction of that there are more people willing to put sort of money on the table that they believe in this. Yeah, I think there's a lot of promising research. Maybe we were talking about cures earlier in Plural, and maybe a combination will be a slight encapsulation of modestly modified cells, or maybe there will be some modest immune suppression that everyone can live with. But I think supporting this as this is a real thing and not an academic exercise, putting real money behind it, I think that's the way to go.
I think there's also what gives me a hope, and again, I'm making a pitch for folks who haven't seen upstairs, is the convergence that's happening beyond type 1 diabetes in the diabetes science. We have one of my good friends, Matthias van Hereth, in the back, and a famous, amazing immunologist in diabetes. The immuno field, the cell therapy field, convergence from other autoimmunity. Gene editing is being applied in a variety of different disease states. Most people have probably seen like the 60-minute specials on sickle cell anemia. And the promise that's happening in these other, pushing the science is different than it used to be. What you can do up in the lab versus what I used to do when I was in the lab is light years different. And we're learning from different fields, and I think those barriers are being broken down because it's not just our same community, it's a variety of amazing scientists leaning in.